Thank you, and thanks for the invite. As introduced, I'm a head and neck surgeon here at UC San Diego, and thyroid surgery is a pretty big part of my surgical practice. So I'm going to talk a little bit today about the role of the surgeon in surgical management in Graves' disease, and we'll have some time at the end to answer any questions. I'll start by saying that in the United States, medical management is definitely the mainstay of treatment for Graves' disease. Combination of beta blockers and anti-thyroid drugs, with most people in the United States going on to have radioactive iodine ablation for attempted definitive management of the hyperthyroidism associated with Graves' disease. Certainly surgery can play a role, and we'll get talking about that. What are the indications for surgery as opposed to these proposed medical managements? Oh, sure.
The one that they wired you with is just for the video.
Sure, no problem. The goals of any treatment modality with regards to Graves' disease, whether it be surgical or medical, are twofold: amelioration of the symptoms associated with the hyperthyroidism, and secondly, ultimate normalization of your serum thyroid hormone concentration. So what are the indications for surgery if medical management is not successful? And that really is one of the primary indications for surgery if the Graves is refractory to medical management, if the beta blockers and anti-thyroid drugs are not effective, or perhaps a patient doesn't tolerate those medications, is allergic to them. A second indication, and I've seen this more commonly in the recent past in my practice, is someone just may have an aversion to radioactive iodine and not wish to go that treatment course. And rarely, but on occasion, someone may actually need surgery still as definitive treatment after attempted radioactive iodine ablation, if that was unsuccessful, or if they want to avoid another dosing of radioactive iodine. In cases where the disease has resulted in a very large obstructive goiter, then certainly no medical management is going to be successful in shrinking the size of the goiter or relieving obstructive symptoms. When I say obstructive symptoms, you think of a large goiter that may cause compression in the neck, and in some cases trouble breathing or trouble swallowing. I will say that surgery is the only treatment that provides rapid and definitive treatment for the hyperthyroidism caused by Graves' disease. If I take you to the operating room for a total thyroidectomy, I promise you that 2 to 3 hours later, you will be free and cured of your hyperthyroidism. That's the only treatment that can be said for. And I would argue that total, as opposed to any sort of subtotal thyroidectomy, is really the optimal surgical treatment. Our literature is replete with reports of surgeons taking out X% of the thyroid gland and describing leaving a sliver here or a little chunk here or 10 grams there. The bottom line is that if any gland is left, there is a defined rate of recurrence of the hyperthyroidism. Obviously, the caveat being if I do a total thyroidectomy on you, you by definition will need thyroid hormone replacement for the rest of your life. It just gets to be a bit tricky if I'm trying to outguess the function of your gland by leaving a certain amount in hopes that that will provide just enough hormone but not too much. In my mind, if you're coming to see me for surgical treatment of your Graves' disease, I'm going to offer you definitive treatment, and in my mind that's a total thyroidectomy. So preoperative consideration with regards to surgical management of your Graves' disease. I work closely with all of my endocrinologists, and we work in concert to manage patients with hyperthyroidism who may ultimately need surgical management. And even though you may be headed towards surgery for treatment, optimal medical management is still desired with anti-thyroid medications and beta blockers. Ideally, when I was taking you to surgery, you would be biochemically euthyroid, meaning your thyroid hormone level would be as close to normal as possible. Additional medical management, and again, this is not routinely used, but potassium iodide, which comes in a couple of different oral solutions, may be given preoperatively as well. And that's typically reserved for patients that don't respond to optimal medical management before surgery. Again, the goal before surgery is to have normal thyroid hormone levels. If the beta blockers and antithyroid drugs don't do the trick, then oral Ki or potassium iodide given 10 days prior to surgery can help out, because that drug, when given, can decrease not only the release of thyroid hormone, but the ultimate production of it as well. It is constrained in time. It has maximal effect, maximal benefit at day 10. So it's not used for long-term treatment. It's just used in a preoperative setting. The reason that we want you optimally medically managed prior to going to the operating room is to prevent what's called thyroid storm. Anyone that has hyperthyroidism has a potential for developing what's called a thyroid storm. Going to surgery is just one event that can precipitate this. I mean, if you get into a car accident or get pneumonia and have hyperthyroidism, that can also precipitate a thyroid storm. But that's something that we certainly want to avoid if we were to take you to the operating room for thyroid surgery. Again, it's a very rare condition and almost unheard of or unlikely if you're medically managed going into the operating room. But what a thyroid storm is really a severe and can be life-threatening thyrotoxicosis. So at the time of surgery or up to almost a day out from surgery, you can have this rapid rate of increase of production and release of thyroid hormone. And think about your most extreme symptoms of Graves' disease and multiply it by 10, and that's what can happen. It can have what can be devastating and sometimes lethal effects on your cardiovascular system. This is not meant to be fear-mongering. This is just educational only. It's extremely rare. I've never seen it, and chances are I'll never see it. So you get to the point where you've thought about surgery for your Graves' disease and plan to meet with a thyroid surgeon. Well, you need to find an experienced thyroid surgeon who has a close working relationship with your endocrinologist. As I had mentioned, what does experience mean? Our literature is full of reports of better outcomes in patients that are treated at, quote, high-volume surgical centers for thyroid surgery. It's hard to put a number on that. I would say if the thyroid surgeon does, 40, 50 plus cases a year, that's pretty experienced, as opposed to someone who may do, 5 or 10 in any given year. The surgery itself typically done under general anesthetic. Depending on how much dissection needs to be done and the size of the gland, can take anywhere from 1.5 to 3 hours. And the hospitalization and recovery time is also really dependent on the extent of surgery. Quick anatomy lesson. Most of you, I'm sure, are aware of this, but the thyroid gland is what we call a butterfly-shaped organ that sits low in the neck. We talk about it in a right and left half or right and left lobe. That's a misnomer. That's just for sort of medical speak. It's just one gland that's connected by a bridge of tissue in the middle called the isthmus. And you can see there's a lot of valuable real estate around it in the neck, the internal jugular vein, common carotid, lots of nerves. And the thyroid gland is highly vascular, even in its sort of normal resting state. That's accentuated significantly in someone that has Graves' disease or hyperthyroidism. Its role is to produce thyroid hormone, which is our major metabolic hormone. It gets an extensive blood supply from above and below, and as depicted in these anatomic drawings, it's intimately associated with the voice box, the trachea, the surrounding blood vessels, and some nerves. And so now we're going to start to talk about thyroid surgery itself, the risks involved, and possible complications. So as I mentioned, thyroid surgery, like any surgery, should be individualized. It's not one size fits all, and what may be required in one person is going to be different from the next. These are just some schematics that show from an anatomy textbook, you know, the kind of the basic steps with regards to thyroidectomy done through an incision in your neck of variable size. We separate the surrounding soft tissue. There's muscles overlying the gland. Those are sort of pushed to the side. And then we get to the actual thyroid gland. We'll talk about some of the possible risks in the neighboring structures, the recurrent nerve and the parathyroid glands. The thyroid's taken off of the trachea, and then you do the same thing on the other side. Now, I apologize if anyone's grossed out. I have a few intraoperative photos. So one thing that I do as part of my practice is a minimally invasive thyroidectomy. So I can take out a total thyroidectomy through a 3-centimeter incision, often done as an outpatient. People can go home the same day, no drains, and they heal up quite well. Here's just 6 weeks post-op, young, healthy. You know, you're back sort of doing your thing within a couple of days. But again, it's not one size fits all. Compare and contrast that to, you know, you can see on this CT scan, this woman with a massive thyroid goiter, her trachea is deviated to the side and even compressed, visible goiter on physical exam, big incision, lots of drains. She's gonna be in the hospital for 3-4 days, recovering from that surgery. So define risks of thyroid surgery and possible complications. You should hear each and every one of these from a surgeon before you sign a consent form for a thyroid surgery. There's going to be inherent risks to receiving a general anesthetic, and then risk of bleeding, infection, and damage to nearby structures. If you have bleeding after surgery, you get a collection of blood, that's called a hematoma, or you can get a collection of fluid called a seroma. An infection leading to a wound infection, a bacterial infection that will require additional treatment. Some of the surrounding structures of note, one is the recurrent laryngeal nerve, and there's one on each side, courses behind the thyroid gland up to the voice box, to the vocal cord, and that controls the movement of your vocal cord. If that was injured during the operation, you may have some voice changes, some hoarseness, or if both of those were injured, you'd actually have some trouble breathing, some respiratory difficulty. Located also on the back side of the thyroid, usually 4 in number, some very small glands called the parathyroids. They're distinct from the thyroid not only in anatomic location but in function. These produce a hormone, parathyroid hormone, that helps regulate your body's calcium metabolism. And so if those were injured, you may have to take some calcium supplements after surgery. And inherent to the operation, but often overlooked and not discussed with patients, if I do a total thyroidectomy, you by definition have hypothyroidism because you no longer have a source of thyroid hormone. So be aware, anyone who has a total thyroidectomy will ultimately require lifelong thyroid hormone supplementation and management by their primary care doc or endocrinologist. I'm just going to go into greater detail about the complications just to educate all of you. Hematoma is the blood collection often recognized early in the postoperative period, even in the recovery room. You're going to get some swelling and some pressure in your neck. You've got to go right back to the operating room to open up the neck, clear out the blood, and find the source of bleeding. A seroma is a delayed fluid collection, usually not blood, just serous fluid. Can often be treated as an outpatient in the clinic just with a needle aspiration and drainage. A wound infection after thyroid surgery is incredibly rare. It's done under sterile technique, and the neck is so vascular it would be almost unheard of to develop an abscess or a raging infection afterwards. So some more anatomy, those recurrent laryngeal nerves that I mentioned, they're branches off of a major nerve in the neck called the vagus nerve, and the anatomic course of each of these is a little different on the right and left sides, and that just has to do with the variable or the anatomy during development, embryology, and they have a variable course, but the bottom line is they sort of course up the side of the trachea in an area called the tracheoesophageal groove behind the thyroid lobes. The common practice and the most sound practice during thyroid surgery is actually positively identify the nerve and trace it up to the voice box and remove the overlying thyroid gland from it as you're dissecting and following up the nerve. Here you can see in this schematic the thyroid lobe is retracted and the course of the nerve here just sort of right behind it. And as we're dissecting along the thyroid lobe, we're right on the capsule to avoid any trauma to the nerve or the surrounding parathyroid glands. This is just another demonstration of how this nerve, recurrent nerve, goes into the voice box and innervates all these tiny muscles that control the movement of your vocal cord. So the videos won't work. I was just going to show you the normal voice box and movement of the vocal cords, and then there's another video or two that showed the lack of movement in a vocal cord after an injury to a recurrent laryngeal nerve. So in cases of thyroid cancer, obviously not applicable here in Graves' disease and hyperthyroidism, sometimes the nerve is actually involved with the cancer and it's intentionally sacrificed during surgery. But again, that would be an unexpected finding in surgery for Graves' disease. The most common cause of injury, if it's not accidentally transected, is just a little bit of traction on the nerves. Nerves are very sensitive, very fickle, and plenty of nerves in the head and neck, just by operating on them, even though they're intact, they go dormant or asleep for a couple of months just until they recover from that minor trauma of being operated on. So when we see an injury to the recurrent laryngeal nerve, if someone has hoarseness postoperatively, it does not imply that it's permanent. As long as they remain functionally doing fine, they're just observed until expected recovery. Although if it was transected, the injury may be permanent. The injury to one of the nerves is usually recognized just a few days after surgery, as opposed to immediately. Having the breathing tube in during your operation causes some swelling of your vocal cords, and so that compensates for the lack of movement. But within a few days, when that swelling goes down, people typically have somewhat of a breathy voice because one of their vocal cords is not moving over. Bilateral injury is usually recognized immediately because the cords are now at rest pretty close together, and they're unable to spread apart. And so that can result in some immediate respiratory difficulty, and that can require a tracheotomy to restore someone's airway. As I mentioned, the best measure for avoidance of injury is to identify the nerve and trace it up and follow it as you're doing the actual thyroidectomy. Common practice, in my practice and in a lot of centers, is use of a nerve monitoring endotracheal tube, and it's a standard endotracheal tube, but it has some electrodes attached to it that you attach to a nerve integrity monitor, and these electrodes down at the level of the vocal cords allow you to determine if what you're operating on is the nerve. You get this audible and visual feedback as you stimulate the nerve, because the vocal cord's moving, and that's being registered on these electrodes. Here's an intraoperative photo. Thyroid's been removed, and you can see the nerve coursing up here, up to the voice box. The reason we monitor is to confirm proper identification of nerve. We get this continuous feedback during the operation, and at the end we can stimulate that nerve and get feedback, and that tells us as the surgeon that the nerve is intact. We're able to verify its integrity. If the nerve is injured and it turns out to be permanent or a long-standing problem with regards to the voice change or hoarseness, there are procedures that can be done. We can inject things into the vocal cord or other procedures on the voice box that will push that vocal cord back into position and improve a person's voice. Another nerve that also comes off the vagus and goes to another muscle in the voice box is the superior laryngeal nerve, and that just innervates one muscle, the cricothyroid muscle, as opposed to the recurrent laryngeal nerve. This nerve doesn't get a lot of press. It's not very glamorous, and typically if it's injured, it's not really recognized, with a rare exception. If it's injured as you're dissecting out the top part of the thyroid lobe, or what we call the superior pole, it may have a subclinical effect, or patients and even the clinician may not recognize that anything has been injured. The voice changes that result are often pretty subtle and unrecognized. Professional voice users, or specifically singers, may note the change because the nerve innervates the muscle that tenses the vocal cord. And so if someone's trying to hit some high pitches, that's what that muscle's used for, to really tense the vocal cord, so they may lose the ability to do that. I mentioned the parathyroid glands, usually 4 in number, 2 on each side, also that sit on the back side of the thyroid gland. And they're usually associated with the thyroid capsule, but not adherent to it. But as we're coming around the thyroid gland doing the dissection, you want to sweep those off and preserve their function. They produce parathyroid hormone, as I mentioned, which regulates your body's calcium metabolism. They have a very tenuous blood supply, and just sweeping them off the gland, just like the nerve can sometimes go dormant, sweeping the parathyroids off the gland can temporarily compromise their blood supply, and sometimes they don't work after surgery, and people need to take calcium supplements temporarily. And so again, we carefully follow around the thyroid capsule during the dissection in order to preserve the parathyroid glands. If one is injured or inadvertently removed during the operation, the redundancy, the fact that there's 4 of them, is often helpful, because you can lose, 3 or 3.5 of them, and as long as that remaining part has a functional blood supply, that will compensate and produce enough parathyroid hormone for long-term function. After you have a total thyroidectomy, just by the nature of the surgery and the fact that these can be injured, it's routine to check a blood calcium level, and you can even check the parathyroid hormone level to determine almost instantaneously within an hour or 2 of surgery whether or not those parathyroid glands are still functioning and producing enough hormone to maintain a person's calcium. The hypocalcemia that may result, so if you lose parathyroid hormone production, the downstream result is that you get a low serum, low blood calcium level, and that can have some significant effects as well. And if the removal is noted intraoperatively, so if I inadvertently remove one, but I know it's a parathyroid, if it came out sticking to the thyroid gland, then I can actually just mince it up and put it back in you. It's called an autotransplantation, and blood flow will be restored to that, and it will then function normally, probably within a couple of weeks. If you develop a hypoparathyroidism, if they lose their function and you start to have a drop in your blood calcium level, there are various signs and symptoms that patients complain of. Typically, it's some tingling and numbness in the fingertips and around the lips. They can have cramping, muscle cramping, irritability, and Schwasteck's and Trousseau signs. Those are just clinical findings. If I tap on your face, your lip can twitch, and if I put a blood pressure cuff on your arm, your hand will twitch, and those are just exam findings that demonstrate low blood calcium. More late or severe ones, people can actually develop severe muscle spasms, tetany, problems with heart rhythm or regulation, and seizures. Typically, if you have any of these things, it's an emergency room visit and you get IV calcium supplementation. Those more minor symptoms are just treated as an outpatient. You get calcium and vitamin D supplements by mouth just to make up for the dysregulation. As I mentioned, if you become symptomatic, you require treatment typically just with oral supplementation. You typically take vitamin D with calcium because the vitamin D facilitates absorption of the calcium in your gut. And if you end up in a hospital or an emergency department because your calcium is so low, you can certainly expect to get some IV to get an immediate correction of that low calcium. As I mentioned, much like the nerve injury, when it's detected, it typically is transient, weeks to months, until the blood supply to the parathyroid glands is restored. Permanent problems are pretty rare, but you'd obviously require lifelong supplementation in that setting. Jumping back to the hypothyroidism, again, just to reinforce the fact that it's not really a complication or a risk of surgery, it's inherent to the fact that I'm doing a total thyroidectomy on you. But arguably, medical management of your thyroid hormone when you don't have a gland is much easier than trying to manage the hyperthyroidism associated with Graves' disease. You might be trading one pill for another, but at least you're getting rid of all the symptoms associated with the hyperthyroidism. If you don't have a thyroid gland, your endocrinologist can start you on a dose of levothyroxine, check your blood in 8 weeks, tweak the dose as needed, and you're probably good to go for the rest of your life with minimal adjustment in that dose. That's all that I have for today. I'm happy to entertain any questions that you may have.
I stepped out for a second and I might have missed it, but a year or so ago on the news, they made a big deal about the under-the-arm incision for thyroid surgery. It was some type of robotic procedure. What's your take on that?
You know, I've trained to do robotic thyroidectomy, but you know, I found that it's probably, from a surgeon's perspective, it's a little more hassle than it's worth, and that was born out of Korea and some of the Asian countries where the patient's body habitus is much more favorable to get that done, and they're much more willing to sort of jump through those hoops to avoid an incision on the neck. Most of my patients understand that, you know, in my hands, the safest route is through an incision in the neck, which ultimately heals up quite well. So it's not part of my practice. There are some centers in the US that offer transaxillary robotic thyroidectomy. It would really depend on an individual's strong preference to get it done that way.
Okay, thank you.
Yes?
Can you talk about the coordination of working with the endocrinologist and how you work the anti-thyroid drug medication into surgery and post-surgery? When do you stop? When do you start the
Sure.
thyroid replacement? And just the delicate balance in trying to coordinate so that you minimize the presentation of the symptoms all over again.
Right. You know, obviously, you know, no one, with a rare exception, no one's going to present to me for a diagnosis of hyperthyroidism, aka Graves' disease. They'll be managed or seen by an endocrinologist first, and typically you'll get started on medication right away if you present in a symptomatic fashion and the diagnosis is made. Again, in the US, typical practice patterns are that you would be managed with anti-thyroid medication and then probably be set up or referred to nuclear medicine to see if you're a candidate for radioactive iodine ablation. So by the time I've seen someone, if they're looking to go the surgical route or if they have an indication for surgery, they're already on the anti-thyroid drugs and the beta blocker, and you know, I just communicate back with the endocrinologist if we, you know, once we get a surgery date, I'll typically have the patient go back to see the endocrinologist, you know, within a week of the surgery date, repeat blood work, make sure that they're optimized and ready for surgery.